name is Gloria Roland, and I'm the head of midwifery and gynecology at Northwest London Hospital, the first Black Africa head of midwifery in UK.
Fantastic.
Yvonne, you've just heard from.
Yes.
Jo Myers, Head of Nursing for Children's Services at Whittington Health and Nurse Consultant in Community Children's Nursing, and the Chair of the Chief Nursing Officer of BME Advisory Group, and the first Nursing Consultant for Community Children's Nursing in the whole of the UK.
Fantastic. A very busy woman by the sound of it. Yeah.
That's the biggest job title I've
I was going to say, does this lady need any introduction? But anyway.
So, yeah, Jane Cummings, Chief Nursing Officer for England.
We're delighted to have you here, Jane.
I'm delighted to be here.
Louise Silverton, Director for Midwifery at the Royal College of Midwives. So good they named it twice.
Hi, I'm Bernal Bissou. I'm the Regional Director for the Royal College of Nursing in London and responsible for the RCN's 54,000 members.
I'm Wendy Brewer, I'm the HR Director at St George's.
Yvonne, Yvette, and...
I'm Lisa Marsh, I'm a caremaker, staff nurse at Queen Elizabeth Hospital in Woolwich.
You're very welcome. So we've got some time, a few minutes now for questions for our panel. So we've got some roving mics, I think, around that. Yep, at the back. So who would like to ask a question? One over here.
I'd like Catherine Gamble. I'm South West London in St George's and a consultant nurse in mental health. I wanted to just hear your comments a bit more about the statistics of mental health in London, because that's one of the things that obviously, you know, sort of I'm very concerned about in relation to particularly people who have schizophrenia, who don't get the opportunity to perhaps express their wishes and desires in the same way that perhaps other people would do because of the level of stigma, not just within their physical health, their mental health, but their physical health.
Yes, okay. Do you want to comment on that, Yvonne?
Yeah, I mean, we can probably get you the actual statistics on the various groups, and just to let you know that there's a lot of work going on in the Public Health Service about understanding that right down to local authority level. And we're working with UCL partners on this, and they're producing quite a lot of good epidemiology. So we can, you know, if you want to give me your details, we can put you in touch with some of that data. Also, I'm really pleased that Chief Medical Officer Dame Sally Davies will be producing one of her next annual public health reports on mental health, which will have a lot of information about both illness and health in it. So that should be out later this year. So there'll be a lot of good stuff in the public domain.
Okay.
Nurse representation on that as well, because it isn't, you know, the nurse expertise is equally as important of perhaps those other people at the table at the moment. So I think that would be really useful.
Yes, I can't promise you that because Dame Sally, it is her independent report. So she is free to go where she pleases, but I think she'll do us proud actually on this one. Yeah.
Thank you. Other areas that people want to comment on or ask a question?
Could I say something?
Yes, certainly, Ben.
I was just going to say, if I could say something in relation to the last question, and what it is that we know that in mental health settings there is a disproportionately high black and minority ethnic population that is served in those services. And the thing that bothers me sometimes is that we wait for a really serious untoward incident, and then there's a whole flurry of activity to address that. And I think that in mental health settings, in secure settings, in the forensic services, we need to be keeping that as a focus in terms of how we organise and deliver the services that support people from black and minority ethnic backgrounds.
Okay. Well, whilst people are thinking, I had one. There's a question at the back. Sorry, I'll ask my question in a minute.
To Yvonne, the public health lady, I'm I'm a practice nurse.
Yeah.
And September through to December, I was very busy with the shingles vaccine. And many of my patients said, why this age group? We had to give vaccines to, I can't remember now, 69, 70-year-olds. There was 2 age groups that we had to give shingles to. And my patients were very upset about it, and they felt it was very discriminative. Why those age groups? So I said, somebody in the big office must have a nan or a grandmother that age group.
Yeah.
But also, as a practice nurse, I do a lot of immunisations for the children instead of the health visitors.
Yeah.
And there's no recognition for that because practice nurses are not seen as public health nurses.
Yeah. Yeah.
And we do a great deal of work. We chase our children, especially with the MMR catch-ups for our older children. And it's very, very hard for mums to bring their children, especially when they've got more than 2 children, to fit it in our hours. So it's very difficult to do that role.
Yeah.
And many of us work in surgeries with just 1 nurse.
Yeah.
So trying to do a whole 6,000 on our list size, on my list size with my practice. So it's very difficult, but we are trying. But on top of that, the mental health patients that come in hardly get a chance to come in because they need someone to be an advocate for them. And if they're living in independent accommodation, there's no one to bring them. Like the good old days, you know, you'd bring all your patients to the practice nurse and they'd have all their screening and all those things done. And when they are ill and when they die, and I find out about it, I'm very sad about it because some of it could have been avoided. Just like having smears, you know, every 3 years, the mental health patients never seem to have it. Coming to the smoking cessation, they have it a real hard time. And so I feel I need to work with my colleagues in the hospitals as well as in the community. So I just wanted to share that. And as a BME nurse, I'm finding it very difficult to be compassionate and be all the things that I want to be because I'm a good nurse when I get hit on all the time. My career's been up and down all over the place. So sometimes I'm up and sometimes I'm down. Just wanted to share that. It's not very easy. Being a good nurse and still being a good nurse. Over 36 years, I'm trying.
Thank you very much. So some key issues there about parity of esteem for people with mental illness and looking after their physical health and screening and so on. I don't know if you want to comment on that, and perhaps I'll ask other panel members to comment on particularly that parity issue. But also comment on the shingles vaccine and your large office.
My large office. So the shingles, so 2 things. I mean, the first and most important thing to say is thank you for what you do, because I don't think people do say that. And we know from the measles catch-up that people worked their socks off and everybody roped into that. Everybody rolled up their sleeves. So I have absolutely no doubt that the practice nurses were very active in that. And, you know, it's fantastic to know you're out there. It is just brilliant. I'll remember that, you know, as the strength of your practice. So thank you for that. And the second thing is about the shingles. All these vaccines are worked through by a very august committee called the Joint Committee on Vaccination and Immunisation. And they may well have grannies in the age group, but actually it's all modelled and worked through about which part of the population is most likely to benefit. So that's where this one landed. And actually it is relatively unusual. There are a few, but it's relatively unusual beyond flu to actually aim directly at an older population. And this was one. And it went down well with older people. But I absolutely take your point. You know, anyone who gets shingles wish they could have had that vaccine.
And does anybody want to comment on this parity of esteem point that was made? Because it's a very good example of how we sort of pigeonhole people into you're either a mental health patient or you're somebody who's coming for screening. I find it very difficult to see the whole person. Does anybody want to comment on that?
I'll ask. It's not often you can shut me up. I suppose that I think you raised some really interesting points, and I'll come back to the parity of esteem one, but one of the things that I thought was interesting was you described very well what you do as a practice nurse. And I would say, actually, every nurse has got a public health role, and practice nurses have got a significant public health role. And I think it's not just health visitors or school nurses that actually have that public health function. And we are about to publish some work between NHS England and the Department of Health around practice nurses, the role that they play, and we are incorporating the role of practice nurses into our community nursing strategy, and actually linking it to both the new integration agenda, how we look after older people with multiple comorbidities, and that will include patients with mental health. And we've talked a lot about parity of esteem, and parity of esteem is not a programme, it's not a tick box exercise, it's a culture, it's a behaviour, it's a recognition that actually we shouldn't be putting people into boxes or into pigeonholes. We should actually be looking after the physical health of those who've got a mental health or learning disability, as much as we look after the mental health of patients that have got multiple long-term conditions. So for me, it's about the culture of seeing the individual as a whole and not trying to put them into boxes.
Okay, thank you, Jen. There's a question over here.
Good afternoon. I'm Liz McAnulty, representing the Patients Association. I'd like to just say thank you very much. It's been a wonderful day today. And although the vast majority of people in this room are health professionals of one kind or another, I think we're all agreed that today is about patients. Yeah. And I think the initiative that's been launched by the Chief Nurse is absolutely wonderful for patients. But the question I'd like to ask the panel, and I know it's not an easy one, but could you just say, one or more of you, how confident are you that we will have the resources to make sure this initiative is followed through over the next 2-3 years and beyond? Thank you.
Okay. Wow. Well, let's ask some of the frontline practitioners about their confidence. So, Gloria, Jane, do you want to comment on that?
Well, I would say from what I've seen this year and towards the end of last year so far, with Caroline coming into post, I think this is the first time we'll really see movement in certain areas. And I will comment mainly about looking at the health of BME people and probably BME staff. A lot of real practical conferences, workshop has been held, and I think they are working towards the right direction. I think it's gone past that time. People say things, people write things, and we don't see any action. I think she's heading towards the right direction. So I'm very confident.
Great.
Can I just say about that, because I think the money is a real issue, not just for the NHS but across all public services, and we are going to be going through a long period of austerity. So I think it's something we're going to have to think about. And one of the things that we know is that actually if you have a more motivated, inspired, enthusiastic workforce, then actually you can get more bang for your buck, as it were. So there's things that we can do within the system that are free, as it were, or cheap, that will improve productivity. So yes, it will be tough and it will be tight, but my belief is that if we do things like we're doing today and work together, I think that we can continue to improve on the services that we give to our populations.
Yeah, Wendy, do you want to?
Yes, I think that it's absolutely essential that we now work towards looking at the quality that we provide to patients, and the support we give to workforce is essential to doing that. So there are all sorts of things that we can do to make sure that we're both improving productivity, if you like, and cost, so not using agency workers, making sure we're reducing our vacancy factor, making sure that we're retaining the staff that we have, and that is all about the soft stuff, which people use the word soft, but actually it's quite hard work. It's about enabling line managers to engage with their staff, and that's really hard for people because line managers are tired too, but learning how to value people and to work alongside them makes such a difference, I think. And that's it's hard work and it takes a long time, but that's where we absolutely have to go, because you're absolutely right, our workforce is key to providing good quality care to patients.
A couple of other comments I don't want to come in, Louise and then Denise, and then come back to you, Jane.
The issue of resources is very, very central to the provision of maternity services at the moment. London has particular challenges. We have a 26% increase in the birth rate, a very high proportion of mothers with complex needs. Depending where you are in London, very high representatives of BME populations, which also come with their own needs, because you do have to remember that being a healthy and good childbearing mother does very much depend on how you were cared for as a fetus and a girl child. And we have many women who were not well treated as girls in their home countries, and that is something that is a problem. Building up on what Yvonne has said, of course, the RCM is going to be launching some work on promotion of continuity of care. We have good evidence the value of continuity of care in maternity services for all women. And if you have continuity of care, you are much more efficient at providing that care, because you don't need to get to know the woman every time you meet her. And by doing that, you also are delivering much more compassionate woman-centred care, because you're developing into a relationship of equals, which is what makes maternity care a success.
Bernard, do you want to?
Yeah, I was going to say that in terms of trying to answer the question, I think the jury's probably still out on that. And from the Royal College of Nursing's point of view, I think that we think that we're going in the right direction, but we have some concerns, and the concerns that we have are around not just all the stuff that you can do around service redesign and trying to get as many efficiencies out of the system as you like, but it still comes down to the bottom line: are there enough people to do what needs to be done? And certainly, one of our big concerns is, at the moment, we don't think that there are enough people. And the other point that we're concerned about is, when you look at altering the skill mix, let's not lose the leadership and specialist component that we need for nurses and nursing and the other professionals. Let's try and get that balance right. And I think that why I say I think the jury's still out is because there's still work to be done in that area.
Okay. Jane, you wanted to?
There's three aspects to resources, and you mentioned about financial resources, but one of the two areas that we have are human resources and material resources, as in equipment. We may not have as much human resources we need, but as Jane has her 6 C's, I've told her I've got my 4 R's.
Oh.
And the 4 R's, because the 6 C's are about the patient care, which is really basic to what we do. The 4 R's is to do with the nurses. We need to respect nurses for who they are, recognise what they do, reward them for what they do, and then report on what they do. Because then when we have positive staff engagement, it would translate into positive patient experience. And so I have a strapline for nurses, which is caring for, caring with, caring about all. And as we begin to care for each other, as today has talked about compassion in all elements, looking after people as human beings with a spirit and a soul, not just as a body, as real people, and we look at each other and relate to each other as real people, then we get more out of our staff that would have a bigger impact on the outputs, and that's what we need to do to have positive results.
Yeah, fantastic.
Well said. I like the 4 R's.
Okay. One more question. Got one more question.
It's great being on this side of the table.
Are you allowed to ask?
Well, Mike. Something that's come up in lots of events we've done in London, and lots of you on the stand have been part of them, is how do we really get boards to take the thing about BME workforce really seriously? I would love to hear from all of you, or a few of you, what you think we need to do to influence boards to start really embracing this issue, because in a sense we often preach to the converted. We now need to be really influencing them in a different way.
Yvonne, do you want to start with that?
I'll start with that. I'm very fortunate because I'm working for the Leadership Academy, and what I'd like to say is that colleagues at the Leadership Academy really take this issue incredibly seriously. We have access to all of the top leaders in the country, and a lot of people in this room and outside of this room who work in the NHS are part of our programmes that we run. And what we are doing now is building into all of our core programmes, and particularly with our top leaders on our new Fast Track programme that we have for senior leaders in the NHS, the importance of this agenda, and that's not a tick box exercise. That is about values, about the importance of senior leaders taking this issue and actually running with it, and it's not easy. Last week I was speaking to the faculty members, the members of the organisation who will be working with top leaders about the issues that we've all talked about here, and not everybody is cognizant or aware of what the issues are for BME staff. They just aren't. And I know as a BME person myself, we talk about these issues amongst ourselves a lot, but it doesn't necessarily follow that others understand or know. So giving people the opportunity to hear about the issues, talk about the issues, and actually finally think about what they do about them. And I have to say, the top leaders that I've spoken to are really interested and concerned about what can we do to make a difference. So I actually feel quite positive, and it will take time, Caroline, but actually I think that we're on a roll at the moment, and I think that things will change.
Yeah. I'll come back to you, Jane. Do you want to?
Yeah, I just want to say something from the frontline staff point of view. I think I've seen a lot of difference. I've seen things changing, things shifting. And I would say initially, people won't talk about black and white. And now, and I think it's something that we should be open about it. We should be transparent about it. And like the trust I'm looking after, 90% of my service users are ethnic minority group. They are majority. Wow. And for me, being in that position I am, I understand their problem. One of the biggest issues for me is communication. I think it's criminal, treating somebody without understanding what you are giving to them. Information is very crucial. Same thing as people that are deaf and dumb. A sign language woman, how many times do you go to a maternity unit and see anything, any leaflet in sign language? None. And actually, if I look at my profile, once a month I'll have a deaf and dumb woman in my service. So it's about looking at those little things there and change it, and actually having somebody that understands the problem and that will change that problem. And I used to say, like we had a program recently where I actually spoke, don't look at the way I speak my accent. Don't look at me as a person. Look at that passion I carry inside me and that compassion that I can actually give. Yes. And if you look at that, I think we'll move forward.
Yes, thank you. Yeah. Jane, do you want to comment?
First of all, I'd like to really commend Jane Cummins from the day she came in as Chief Nursing Officer. Actually, before she came in, I actually saw her at a meeting and I introduced myself to her and I said, by the way, I'm the chair of your advisory group and you need to come to my conference because it's our conference. It's called the CNO BME Advisory Group Conference, so you have to be there. And she goes, well, I haven't got my diary yet and I haven't even started. But as soon as she came into post, I found her again and she got out her BlackBerry straight away and she found a date and she said, yes, I'll be there. And from the word go, from the time we mentioned about the BME issue, the BME issue's been there from the word go. The NHS came into existence in 1948, and in 1949, Caribbean nurses were invited over to England to help to prop up the NHS. It would not be here today if it was not for Caribbean nurses and other nurses from other parts of the world, even up to today, that are in this country helping out in the NHS. And then I met Caroline Alexander, NHS London region, and I heard her at the BME, at the RCM summit about BME midwives. And what I love about her is straight away, what are we going to do about this? This is going to be one of my priorities. And for years, we've been hearing, go and get the facts, go and get the data. It's not anecdotal anymore. And the fact that Jane can stand on the platform and say, we recognise, we understand what you're actually saying, we want to help you. And it's actually in their priority areas, it's reflected in this audience today. As Yvonne mentioned earlier, it's very rare to come to a conference like this and see more than 1 or 2 or 3 BME people. There's a nice widespread which actually reflects our population, which makes it really, really encouraging. And I think what we need to do now is to move forward together, acknowledge that whether you're black or whether you're white, we're all human beings, and the black workforce has a lot to offer. I run an eczema clinic. And did you know black skin is different to white skin? It's a fact. I was sitting on the panel for the NICE guidelines with dermatologists and specialist people, and nobody actually recognised or actually spoke the fact that black skin, actually, if they've got eczema, actually looks different to a white child with eczema. And that's because it looks different, the GPs sometimes don't know how to diagnose it, they misdiagnose it, and then they mistreat it. Because I was black, I was able to say that on this panel of all white specialists, I was able to say by the way, black skin is different to white skin, so we need to think about this, this and this. And as a result of that, in the NICE guidelines, they now say children from Asian, Caribbean or African descent, their condition may present differently, and we need to consider that when making a differential diagnosis and treating them. That's just a small example of why you need BME people represented at all levels, from the ward to the board, in the planning areas, when you're writing strategies, when you're writing policies, because you can actually speak up for your population and ensure that we're providing the best care possible. All we want to do is provide the best care for all patients, regardless of their ethnicity, regardless of their culture. We're in a multicultural organisation, a multicultural country. Let's treat all our multicultural people with equity by providing multicultural staff.
Fantastic. Thank you. Well said. Okay, I'm going to move us on, because we're going to listen. Joan gave Jane a fantastic introduction, so I'm not sure I need to do any more, other than to say we're absolutely delighted that Jane Cummins is with us today and has made time to talk to us at this conference. Indeed, I'm not sure that we would be sitting in this room today talking about compassion in practice if it wasn't for Jane. So over to Jane. Delighted that she's with us today.
I think so.